All right, let me just hit record. Dr. Shishebor is professor of medicine at Case Western Reserve University of Medicine in Cleveland. He's a world expert in peripheral vascular disease and limb salvage therapy. He's also the president of the University Hospital's Harrington Heart and Vascular Institute, and he directs the institute's clinical, educational research, and administrative programs. We're really excited to have him speak at our interventional conference today, and he's going to take on an extremely important topic. And Dr. Shishebor, thank you again for taking time out to speak at our conference today. We're really excited to have you here.
Well, thank you so much for inviting me, and thank you for having me this morning. Thank you. I don't know who is on, but all the folks that taken the time this morning to be here. Have a special connection with Yale. Obviously, a lot of my friends are there. Dr. Mehdi, Dr. Ataran, and others. And just gave grand rounds there about maybe a year ago. I don't remember now, but as I mentioned earlier, we just recruited a couple of your fellows, interventional fellows and EP fellows, Dr. Yolanka Castro and Dr. Shashank Jain. So we are very excited about the relationship, and we are actively working around research with each other. So it's been fun. So I feel like I'm giving a lecture to my own program or to my own family. So I really appreciate the opportunity here. The purpose of this talk, and I give this talk usually to the fellows that are trying to decide which direction they should go. Either they should do coronary or structural or endovascular or a combination. And the purpose of this talk is to try to highlight that endovascular skills nowadays in the field of interventional cardiology are necessary foundational skills that every interventional cardiologist needs to have to some degree. Whether you are doing a coronary work because of high bore, impella, ECMO, balloon pump complications, or we are doing a structural heart disease and the complications associated with the structural heart disease, or if you're doing endovascular, which basically aligns with what I'm going to be talking about. So in all three major branches of interventional cardiology, these skills are going to be necessary. So with that in mind, let's move to a case that maybe will highlight why this is so critical. So this is a case I was involved with, many years ago, over 13 years ago, 12 years ago, my previous institution. He's a 67-year-old male who came in with coronary artery disease, status post previous PCI at an outside hospital, who now presented with some chest pain and shortness of breath, and had a troponin of 2.14. And this is a patient I had seen at Cleveland Clinic at the time, and that was at Cleveland Clinic at the time, and he was already treated with clopidogrel at that time and heparin. He was HIV positive, and he was on antiretroviral therapy. He had, and as you can see, significant coronary artery disease with prior interventions throughout the years since 2009. And he was known to have a AAA at 4.8 centimeters. He also had a couple other comorbidities, home oxygen. So, a little bit high risk with diabetes and AFib and all the comorbidities that we are used to. And a number of medication from home, which is not really that important. His labs again, by the next day, the troponin had come down. So he had a non-STEMI. And these are his other labs. I think they're not that critical. I think one thing to remember is that his hemoglobin was 12 and his platelet count was 175,000. These are his coronary angiograms. And again, this is not the point of the presentation, but just you can see there's a lesion here in the mid to distal LAD. Play it one more time. And here's another picture of it. It's about 60%. As you can see, if you don't engage well and you have a streaming, you can even miss a diagnosis, the severity of the lesion. But that's not the point of the presentation. Here is a couple of other shots of the left system. So it's more distal. And here's another shot of the left main and the circ. You can see that the circ is also subtotally occluded. So we're dealing with the LAD and circ. And then here are the pictures of the right. So you can see that there is a 90% lesion at the mid to distal right at the junction of that stent, the previous stent that has been placed, or a little bit beyond that. And here is another view of the right. Looks like they're a little bit damp at the ostium. They're in a branch. But in any case, the operator at the time one of my colleagues at the time had decided that, you know, he was going to go after the right coronary artery. So they started the intervention, they passed the wire, ballooned it, routine stuff, and I put another stent, and they got this result, which seems to be reasonable, So at this point, they wanted to, the patient was obese, so they wanted to exchange a 6 French long sheet for a 7 French short sheet, so that the patient could go to prep and recovery and have his 7 French sheet pulled. Because of tortuosity and the size of the patient, they had decided a longer sheet would be a better option here than a shorter sheet. So they had the 6 French long, 35 centimeter sheet. They wanted to put a short sheet. In the process of doing that, the patient has some leg discomfort. They said that they confirmed that the J wire was in the descending aorta. They placed a 7 French 35 centimeter sheet because of some of the difficulties they had. And again, I wasn't there, so I don't know exactly what was going on. But once they put the 7 French 35 centimeter sheet, they couldn't get any blood return. And there was dampened waveform when they connected it to the manifold. So at this point, you know, they kind of a little bit panicked, in my opinion. And they said, you know, at that time, they were doing the case in Ruden. This is many years ago. And they decided that, you know what, let's just do a manual compression. We just hold pressure. We don't get it. We are not getting a good pressure. There's not blood flow coming back. And, you know, maybe we just pull it out and just hold pressure, which is the worst thing you can do, in my opinion. You always want to find out what's going on. And you don't want to ever hope for something that's going to go right. You always want to figure out what's going on before you initiate the process. So don't ever hope when you're doing interventional cardiologist, because you don't want to make a mistake. So approximately 80 minutes into the manual pressure on this patient, the patient started complaining of a right lower quadrant pain. But the patient was hemodynamically stable, according to them. He appeared to have adequate hemostasis after 90 minutes of manual pressure on the table in the cath lab. And the plan was that, given that he was having some pain and they had some difficulty, to get a CT of the abdomen to make sure there was nothing going on. So they transferred the patient to the hospital bed to transfer him to the prep and recovery and go for the CT, where the patient suddenly became unresponsive. There was a weak crowded pulse, and basically the patient arrested. Patient was in PEA. They started chest compression, ACLS for about 15 minutes. They quickly put him back on the table, and that's when they called me because the operator that was dealing with this case did not have the endovascular skills to manage this patient. So we quickly, we arrived at that time. By that time that I had arrived, I remember they were calling the patient for 15, 20 minutes. They had gotten an access on the left femoral artery, and they had gotten an ABG. The lactic acid was already 7.7, and the patient's hemoglobin was 5.6. So I quickly asked for a 5 French IMA catheter and a 5 French pigtail. Now, IMA is one catheter. You could use a sauce. You could use many other catheters, but this is the catheter I like to use to go up and over. So we came in an up and over technique. So the first lesson for this presentation is that every interventional cardiologist, I don't care what specialty or what area or branch of interventional cardiology you're going to build your career on, you need to know how to do up and over angiography and get up and over access and bring a sheet from the left side to the right or from the right to the left. Every interventionist needs to know that. The other thing is that every interventionist needs to know how to do DSA imaging and how we do this. These are not very difficult and can be easily learned. So we took a little picture here because I was worried about the abdominal aorta. To be honest with you, I knew the patient had an aneurysm of 4.8 centimeter. I was worried that maybe they had ruptured or compromised the abdominal aorta. And the abdominal aorta looked okay here. So we decided to take more pictures down. And this was in a room that was not very feasible to do a lot of peripheral, like high mag imaging. So anyway, despite that, we got some images. And here is the image of the iliac. And you can see that there is a huge perforation there right in the groin. I hope you guys can hear me. And my sound is clear. It's hard to know.
Yes, we can hear you well.
Okay, great. So there was a extravasation, extensive extravasation, as you can see here, to the retroperitoneum with significant bleed. So we immediately said, let's go up and over and take care of this case, put a cover stent or something. So the first thing is that you want to quickly hold pressure, right? While you're waiting for the equipment, whatever you're going to do. As soon as people are holding pressure, you then have to bring a sheet. And this is what I mean by up and over technique. So we're coming from the left side to the right side with a sheet. We place a sheet here. We have a wire across, and we were quickly able to put a vial on and deal with the bleeding. And here's another picture. But unfortunately, as you have probably seen in these cases, in every hospital in the United States, there's 2 or 3 or 4 of these that occur, probably a year, if not more. After hemostasis, the patient is stabilized under pressure, under pressors, but unfortunately had significant abdominal distension. He was now in refractory metabolic acidosis. His pH was 6.9, lactic acid was 14. He was fighting the vents. He had to be paralyzed because of his extensive abdominal distension. We consulted general surgery. They said the abdomen had compartment. And basically, after prolonged hospitalization and effort, the patient unfortunately did not make it. So the lessons I hope from this case is that are the things that we have already discussed, that every interventionalist need to know how to do crossover approach, how to take a DSA picture to at least be able to identify the problem. Now, in my opinion, I think you should also have some idea about some of the tools that we have to deal with these perforations, because all of us are going to be dealing with this, whether you do coronary, structural, or endovascular. These are things that you're going to need to know how to do. So today, I was going to go over some of these complications that require endovascular skills and to kind of highlight some of those tools that you may want to be familiar with in dealing with some of these complications. So typically, we do our procedures either from the femoral approach or the radial approach. There's been obviously more push towards the radial, but radial is also not without complications, as you can see here. On the femoral side, obviously, because of impella, balloon pumps, and ECMO and TAVRs, we're still going to have complications. So you still need to know how to deal with femoral complications as well. So with that in mind, let's move on to the first one, which is bleeding. So this was a case that one of my colleagues, again, was doing. And this is the older days when there were a limited number of folks that did endovascular procedures. So where I was practicing, I was the only one, myself and another operator, were only 2 people that actually had endovascular skills. And many of our interventionalists were older, trained interventionalists that really had very little idea about endovascular procedures to be performed. I think now the fellows are getting much more exposure, and that's great. So this was a case of a left main that was being treated, and they treated left main. As they were coming out, they noticed this. So this is where, we work with fellows, we work with staff. I mean, these things, unfortunately, we have to be very careful. And they were not sure what was happening. The patient was hypotensive, was not doing well, hemodynamically very unstable, complaining of pain. So immediately, as you can see, the hands come into the picture, holding pressure. But the first step was giving up and over. This up and over technique is extremely important. And this was a patient that already, pulled it, that closed the groin already with a perclose. So again, similar to what I had shown you, when you have a bleeding issues, the first thing is manual compression. Manual compression. Nobody should be just standing around and just watching. There should be multiple hands, and you got to make sure that you're high in the belly and that you're really covering, because most likely this was a high stake or something like that that led to this. The second step is balloon tamponade, just like the coronaries. Get the balloon tamponade while you can think. You can analyze what's going on. Make sure you send some blood for type and a screen. Transfuse the patient. Get the patient hemodynamically stabilized, make sure you have the right equipment to be dealing with the problem. So that balloon tamponade is extremely important. And I suggest using longer balloons, peripheral balloons, than shorter balloons, so you don't miss the perforation. And be aggressive with the sizing. When we're talking about iliac and common femoral perforations, usually we are talking about a 7 or 8 millimeter balloon, and unless the patient is much bigger and requiring bigger balloons. So 7 to 8 millimeter balloon are usually the ones you want to use. And that's a little bit uncomfortable for folks that don't do endovascular procedures, because in the coronary, we are using 2.5, 3, 4 millimeter balloons. So when you say 8 millimeter balloon, they're just not comfortable. They don't, if you're not using these devices on a daily basis or a weekly basis, you may be uncomfortable and not be familiar with the names or the size or those kind of things. As I wrote here, is that the next step is to stop and think and make sure that you have the right mindset and process in mind. And then make sure you have the equipment and choose the appropriate size and equipment. So the first step when it comes to perforations is knowing what covered stents are available. And here I've mentioned one of them, which is the Biobond, but there are others. There is the BVX stent, that is a balloon expandable stent for iliac perforations. But for external iliac and common femoral, I still stick to the Biobond because it's self-expanding covered stent. And it comes in different sizes and diameters, so you need to be familiar if you have 018, Biobond or 035 Biobond. So you have to be familiar with these things if you do coronary or structural or peripheral intervention, so that you know what size sheet you need, what size wire you need, and how you need to do these procedures. So in this situation, we came, and this is, like I said, from many years ago. I had just become actually faculty at the time, 13 years ago. We put this Biobond, but we noticed that there was still some leakage. Now, the key to this is to do this under DSA, because you could miss. You could think that you got the perforation, but you really didn't. And here, we had still some extravasation. I took that slide out, but we had to go back in and post this Biobond and make sure we had good apposition. You have to be careful with some of these self-expanding stents, because if you undersize, they won't expand. They are not like balloon expandable stents that you can keep growing them like the coronary stents. The self-expanding stents are limited in growth. So if you undersize, you will be in trouble. So if you're not sure, it's worth IVUSing. I know it's challenging because the patient is bleeding, but you don't want to make a mistake and put a 2-3 millimeter smaller diameter stent into an artery, because you will have a hard time growing the stent. And when it comes to the radial approach, obviously we are bleeding around the radial approach. We've seen bleeding in the arm, in the wrist. We've seen bleeding in the forearm. We've seen bleeding in the bicep. The treatment for radial artery bleeding is obviously putting a cuff pressure around the bleed, going up to 10 millimeters of mercury above the systolic for 5 minutes, and then checking to see how things are, and then repeating that every 5 minutes. So I usually use a cuff pressure. I go up about 10 millimeters of mercury above the systolic for 5 minutes, and then I keep repeating. Make sure you're using a bigger cuff rather than the smaller cuff from the standpoint of width, so that you're covering more surface area when you're dealing with these perforations, because it may be tough to know. If you're still having trouble, then you have to get groin access. You have to come from the top. You have to find out what's going on. And you can get compartment in the forearm. So you really have to be careful. In the bicep area, it's harder to get a compartment because it's a bigger compartment. But in the forearm, you can get compartment. That's why it's extremely important that you address these immediately. How about dissections and high stick? I'm sure at Yale, you guys never have high stick because you guys are perfect. But unfortunately, we do. So here is a 69-year-old female obese patient with 320 pounds, multiple comorbidities, including obstructive sleep apnea and diabetes, who has had multiple prior interventions. This is, again, an old case from my previous organization, but 16 prior stents. So going for a left heart cath, they did the cardiac cath, and then they wanted to close. So they were doing an angiogram to see what they should do. And here's what happened. Well, let me play it one more time. So this probably happens once or twice a month at every hospital, if not more often, especially in July, August. So the first thing is that you should never stick a patient above the pannus. As you can see by the shadow here, and I don't know if you see my mouse, the pannus is here and the sheet is going above the pannus. You have to lift the pannus and they get access under the pannus, not into the pannus or on top of the pannus. So that's the first lesson. The second lesson is that I always tell my fellows, do not go above the groin crease. You have to lift the abdomen or the pannus or the tissue or the skin, not to go above it. And this is a very, very important point. I think this is probably number one mistake that folks make. And in the older days, we didn't use ultrasound. All these cases I'm showing you is when we didn't use ultrasound-guided groin access. And I think that that's mandatory now. Every lab, every intervention, regardless of what it is, should be done with ultrasound guidance. There is no reason not to use ultrasound. And in our lab, 99% of the time, we use micropuncture. So it's ultrasound with micropuncture. But then the question is that now that this happened, what are you going to do? And so you have a high stick situation. Looks like there is a tear here or a dissection, whatever has happened. And the access is actually seems to be above the inferior epigastric artery, way in the abdomen. Is a very obese patient. So what's the safest thing to do here? Is it safer to just put a perclose and close it? Is it better to do manual? Personally, I think manual is not a good idea in these very obese patients with very large panuses that have a very high stick, because sometimes it's hard to control the manual pressure. So this is what I suggest for dissections and high access. I think that especially if you have a high access, you need to confirm, and you have a dissection potentially. First is that you need to confirm that you're in a true lumen. And where are you in true lumen? Where is the point of entry? Meaning that you entered subintimally at some point, and then somehow the wire or the sheet was became luminal because you were able to do the procedure. Now, was that at the aorta? Was that at the iliac? Was it at the common iliac or the external iliac? So it's extremely important to know where is the re-entry point and where are you true lumen. Most retrograde dissections are benign. You don't need to do anything. So remember, type B dissection, we typically treat it medically. We don't intervene. Now, if you dissected all the way up the aorta, that's maybe a different ballgame, and you have compromised some of the visceral branches. But for most of the dissections that we create by doing our procedures that we do, you can just pull your stuff out and the patient will do fine. These are retrograde dissections. Do not inject hard or push the wire too hard. So the point of being an interventional cardiologist is about finesse. It's about finesse. It's not about force. So you should never force anything. You should never force anything. If the wire is not going, there's a reason for it. If the balloon is not going, there's a reason for it. And you need to figure out the reason and work around the problem, not to use force. We don't use force in interventional cardiology. It's all about finesse, technique, understanding the mechanism, and trying to address those issues. If you cannot figure things out, remember we have other technologies that can help us, guide us. And IVIS is a great tool to use to try to help us understand, are we luminal? Are we subintimal? Is it a clot? Is it a dissection? What's happening? For high access, I recommend closure for most of these. And I usually recommend getting contralateral access and kind of monitoring the situation from the top. Because maybe the perclose is not going to take, maybe there is a problem. And usually the high access patients are obese patients, and getting manual compression on them is difficult. For closure, I recommend perclose because you can have wire access through the perclose, unlike the AngioSeal or MINX or other devices that are out there. And that's why I use usually perclose for high access. So in this situation, as you can see again, you need to know how to do up and over. I have a sheet here, I have a wire across, so I'm ready. If anything happens, I can balloon tamponade this, I can put a covered stent. I have all kinds of options available to me, so I'm safe. And then I came with a perclose under fluoroscopy, making sure that I don't, this, because there's not a lot of muscle here, we're in the abdomen or pelvis. You don't want this thing to bend on top of the artery, kind of like this. So you want to watch this and make sure that you're getting into the lumen. Now, it's not good for your hands and radiation, so you need to minimize that, and that's very important. And I'm not happy that my fingers are there and dealing with this, but you have to be very careful. So we did the perclose, and after the perclose, now we can take an angiogram and see what's going on. Like you want to know what's happening. You don't want to be blind to things and then send the patient to the floor, and then somebody calls you 2 hours later and tells you that, the patient has ischemic foot, or there's no Doppler sound, and now you're dealing with all of that. These are things you should be able to deal with in the cath lab and take care of. And you guys are lucky because you have very advanced interventional endovascular operators that can help you there. So you're very, very fortunate that you have folks like Dr. Mehdi and Dr. Ataran and others that are there that are to support you. So here we saw this, we thought this was a clot. I wasn't sure, to be honest with you. So I did some angiojet, and it wasn't getting relieved. So we took some pictures distally to see if there was any embolization. There was no embolization. So I said, you know what, let me IVUS this and see what this is. This is weird. And why is this thing is there? And turns out, and these are not videos, these are just still images, but this was the point of entry into the subintimal space. And if you can see here, this is the lumen on the bottom, and this was a subintimal space. And basically what had happened is that that come from a subintimal space and enter the lumen. So that radio opaque area that you see, this area, let me go back. This area that you see is the false lumen, and this is the true lumen. And that false lumen is now has hematoma, and I'm not able to, or maybe potentially even thrombosed, and I was not able to get it open. So instead of putting a stent, I decided to treat the patient medically at the time and see what happens. And actually the patient did well. So it's important not to be also over aggressive in treating this. Stabilize the situation, deal with the complication, and then see how the patient is doing. You don't need to make it perfect. You don't need to make it perfect. So how about occlusion? So we talked about perforation, we talked about high stick, we talked about dissection. Now how about occlusion? Well, this is an 88-year-old male, 140 pounds. This is a thin patient who had severe coronary artery disease and COPD. She had critical aortic stenosis. And again, this is an older case. My colleagues were doing balloon aortic valvuloplasty. These are her iliacs when they did their angiogram, and they decided that they were going to go from the left. As you know, valvuloplasty 12 French sheet at the time. I don't know what they use now. I don't do structural procedures, but I think it's still 12 French. And basically, they went in for a procedure. They did the valvuloplasty. I put this for our structural colleagues so they enjoy it. And then afterwards, this is what happened. They did a perclose, the two percloses, pre-close. And after they did that, the patient was complaining of leg pain, was uncomfortable. So they went with the IMA here. They took a little picture. They saw this. So they called me. They said, Mehdi, what should we do? I said, well, let's see what's going on. So again, up and over technique, be able to cross. We crossed this lesion. We took some pictures distally first, because you always want to know what you're dealing with at the baseline before you manipulate this lesion, because you don't want to go balloon this lesion and then you embolize and you don't know, is it a new occlusion or an old occlusion? So it's always helpful to take a distal angiogram as a baseline before you start manipulating, especially if you think there is thrombus, like this is thrombus, or this is a closure of the vessel with the pre-close that they had done. So I felt that this was most likely thrombus. And again, if you feel like you have thrombus in this situation, you need to know the equipment. So one of the things that we use is angiojet. Now there is a number of other tools. There is a penumbra, there is a Rotarex, there is other devices. You need to know one of them. We have all of them here, and I'm sure you guys do too. So just be familiar with how to use some of these. And at this moment, I think it's useful to get somebody that has endovascular skills and uses these technologies routinely to come and help you. That's why we work in a team format and we work together. So these patients obviously usually are not a candidate for lysis because they just had a procedure. So lysis is not a good idea. You need to do this mechanically with angiojet or penumbra or Rotarex or whatever device that you want to use. And usually that's all you need. Just take out the level of the clot, open up the vessel, and let's see let the body's autolysis mechanism work and allow the vessel to open up. And usually these patients do okay. And you can then have them follow up with your endovascular specialist to make sure that they are doing okay. If the patient, and most of these patients, in my opinion, are too morbid, like this patient had critical AS, was getting valvuloplasty to see how she would do. She was too high risk for TAVR at the time. And so this is not a patient that's going to do well going to the OR for common femoral endarterectomy and general anesthesia and those kind of things. And that's why, obviously, we have a great relationship with our vascular surgeons and we work closely with each other. And I think it's always helpful to get them involved. But a lot of these patients who are bleeding profusely, like I showed you in the previous cases, or are very obese and have multiple coronary stents and significant CAD, are not your low-risk patients that you can take to the OR. And my experience is that when we have taken this patient to OR, they have not done well. And usually we have had major complications. I think these are things that need to be done in the cath lab. And knowing the mechanism of what happened obviously is very helpful. when you're dealing with these occlusions or dissections or whatever it is. So in this situation, after doing some angiojet, this was the angiogram. I wanted to know what was going on, so I IVISed it. And by IVIS, we noticed that, yes, this was clot that was there because this vessel was open before, and now we have all this junk in there. So there's a little bit of a dissection, and there's some clot. So I decided to stent it at the time. And, don't be afraid to stent the common femoral. I think it depends on the type of the patient. If you have a 38-year-old, you're doing a cath, well, I don't want to stent that patient. That patient probably would be better off with the endarterectomy in a stable situation. So stabilize the situation, get the blood flow going, put the patient on heparin, maybe the next day or the day before, the day after, consider the patient for endarterectomy. But I wouldn't be sending patients with critical AS to the OR under general anesthesia for common femoral endarterectomy in their 88-year-old because they won't do well. So this is a patient that needs to be done in the cath lab and we need to take care of. Now, here's a mistake that I made at the time because I was early in my career and I put a stent, a Viobond stent in this patient, I decided. Now, I probably would not have put a Viobond. I would have probably put a self-expanding stent. And the mistake I made is that look at the size of the vessel. If you measure here, you see 1, 2, 3, 4, 5, 6, 7, almost 8, 7 to 8 millimeter vessel, and I put a 6 millimeter stent, in this vessel. So after a lot of ballooning and expansion, I was able to get it to about 6.5, 7, and get a stable situation. But extremely important that we size appropriately. So using IVIS as a guidance is not a bad idea. And with experience, you get better at it. And I was able to get it at least in a reasonable situation. So remember, when you have occlusions, sometimes surgery is better, but it depends on the patient. 88-year-old, critical AS, probably not going to do well with general anesthesia and major surgery. 90% of these can be dealt with in the cath lab if you have operators that can deal with this. And usually they require some thrombectomy to take the clot out. Sometimes we have to put a filter in the SFA to protect the distal foot. And if you need to stent it in the right patient, it's very reasonable to stent. It's not a sin to put a stent in the common femoral. It's not something we do routinely on a daily basis, but to save somebody's life is very appropriate. And then I'm going to finish with this, and this is, well, actually, no, I have a couple more slides. This is a brachial artery, so moving from femoral to the radial approach. This is a brachial artery occlusion. So this is a patient that had a brachial approach and now has a occlusion of the brachial artery with thrombus. This is a surgical management. So please, despite the fact that I told you on the femoral side, endovascular is the right approach probably 90% of the time. When you have brachial occlusion, 100% you should send this patient to surgery, in my opinion. It's such an easy procedure. It's very superficial there in the arm. It can be done under local anesthesia with a small little incision, and these patients can get Fogarty and embolectomy surgically with no problem. This is not the patient you want to put catheters in, potentially embolize to the hand, cause ischemic hand, and have issues with that. And then lastly, Radial Pseudoaneurysms. Obviously, we get these in the groin. We can also get them in the radial. So usually this is the feature of them. They have this yin and yang, the to and fro that you see by ultrasound. There is usually a track. You want to have a good sense of the track, so you stay away from the track when you inject these. Again, getting your endovascular specialist involved is very helpful because we inject these with thrombin, and 99.9% of the time we can deal with this. If they have a short neck or a wide neck, we can come and put a balloon to protect the native arteries and then be able to inject these pseudoaneurysms and deal with them. And these can happen in the radial approach. This was a patient of a colleague of mine who had a large pseudo after a radial approach. We put a TR band for 24 hours at home, and the next day the patient came and the pseudo was gone. So you can even use a TR band to deal with the radial pseudoaneurysm. And with that, just want to thank you. I hope I didn't bore you with this, since you guys have very high-level interventional folks that work with you. And I know you guys have no complications from what I hear from Dr. Mena. He says that, yeah, we are perfect. We never have high stick. We never have dissections. We never have occlusions. So I hope I didn't waste your time.
No, that was wonderful. I think it's tremendously helpful. We see all of these complications as you do, and it's always good to look over the various ways to manage and how you're doing it. A couple of questions I had. You did mention about the up and over technique. Many of us are facile with that and able to do it in terms of in times of emergency. But what do you think about using radial or brachial axis as a second axis, or using equipment such as R2P, etc., to deal with these complications? Or is that something that you do not suggest?
Yeah, I think unfortunately in the older days and the cases I showed you, and that's a good point. Maybe I should add a couple of slides on that. Now we have R2P technology, and we are able to come from radial. And if you're doing let's say you have an impella that you moved and you have a radial access, you're doing a coronary procedure from the radial. I think you can manage a lot of these with the radial. The one challenge with the radial is that the viobond is not very long. So if you have a perforation and you need to put a viobond or a covered stents, we still don't have very long covered stents that may reach to the common femoral. I think for the iliac, they will reach, but not for common femoral. We do have self-expanding stents that are very long on 170, 180 millimeter rapid exchange. So we have stents, self-expanding stents, not covered stents. We do have balloons, and we obviously have the sheets, but we don't have covered stents. So that would be a challenge. Now, what you could do potentially is to come from the radial, put a balloon, tampon out, while you're getting access on the contralateral side, getting up and over, come in to treat if you need a covered stent. The other thing is that depending on the size of the artery, the viobond, as you know, has an 018 system now. The 018 system up to 7 can go through 6 French. Once you go above 7 millimeter, you have to have 7 French sheet. And for the radial, that may be a little bit big. I don't think we have a 7 French R2P. There's only 6 French available right now.
I see. That's a good point. And you did briefly touch about a potential for aortic complication. Do you want to maybe say a few things about that? How to identify aortic rupture, and what is like the basic equipment that we should have to deal with it? Such as, do you have a preference for balloon, such as Coda balloon or something, and what size sheath?
That's a great point. So in my lab, I have an area that is labeled, and I'm in the lab today, so I don't want to bore you. I would have taken the iPad and showed you, but I have an area, it says Coda balloon. So there's a cabinet that has a Coda balloon and has a 12 French sheet. I did that in my previous institution, and I did the same here, because when you're doing these complex procedures, you need to have this balloon and a 12 French sheet available at all times that can be eminently available to you. So I highly recommend that at the minimum, there is a Coda balloon, at least 2, because sometimes they may fall, they may rupture, I don't know. So it's a good idea to have a Coda balloon and a 12 French sheet available for emergencies. We do a lot of aortoiliac cases, and now with the TAVRs and everything else, I think that's the first step. So if you have an aortic catastrophe or an issue during a TAVR or impella or endovascular procedures, when we are trying to fix these vessels, is that the first step is that to put a Coda balloon and do an aortic occlusion. I think once you have that, then you can think as to what are the approaches to deal with it. We have stent grafts we can place in the aorta. I have done even before 2 kissing, covered stents to deal with these. 90% again, we can deal with this, because who wants to take a patient that is bleeding from their aorta to the OR, who is on anticoagulation or antiplatelet therapy, because that's what we are doing, right, in the cath lab. So you have to take all these things into consideration. I think in the past, we've had a very low threshold or a very fast reflex to just call vascular surgery and think that they go to the OR. And I think we were burned in many cases, because we were taking patients that were on dual antiplatelet therapy, they were on full anticoagulation. At that time with bivalirudin and 2B3A, thankfully we don't use any of those things anymore. So we are much safer, because heparin we can reverse. But when we were using 2B3A and bivalirudin and all those anticoagulants and antiplatelet agents, we used to get in trouble, and these patients wouldn't usually do well. Now I think, both from a standpoint of we are not using those non-reversible, meds. On top of that, we have so many endovascular tools in our armamentarium that we can almost 99% of the time deal with these issues in the lab. The one area that this does not work is when you identify bleed 8 hours, 24 hours later. Those patients don't do well, in my opinion, when you take them to the lab. because when you bleed and there's a hematoma, that causes inflammation around the vessel wall. And I have not had a good experience with those patients. Those patients usually need to go to the OR for evacuation of their hematoma and dealt with in the OR. And even those people don't do well either, to be honest with you. But in general, when we have brought patients back after 8, 10, 24 hours of bleeding because it was missed or people didn't recognize it for some reason, they don't do well, you know. We just had a case actually like this a couple of weeks ago here. You know, one of our fellows, and during the procedure, put a sheet through the inferior epigastric. So in exchanging the sheet, going from a 5 French to a 6 French from the groin, the wire, I guess, pulled back. When he advanced the wire went into an inferior epigastric, and he didn't realize. And when he went to exchange the sheet and he pushed the sheet, somehow the wire had gone into the branch of the inferior epigastric. So he had perforated the inferior epigastric into the basically psoas muscle. So the sheet was sitting in the psoas muscle. And one recommendation I would make, and I didn't go over this in this presentation, that's a case I'm going to add to this presentation, is that when you're dealing with this type of perforation, you have to coil distally and proximally, or you have to coil distally and put a stent graft proximally. If you don't, through the collaterals, because if you cover it with a stent just in the main vessel, through collaterals, the branch is going to get feeding and it's going to continue to bleed through that branch. So if you have a branch, you have to coil distal to the branch that is perforated, and you have to coil proximal, or put a stent graft proximal and coil distal. That's a mistake I have made before in my career, to be honest with you, in dealing with one of these bleedings. And I learned in the hard way that, you always need to coil distal when you have perforations that are outside of the main vessel in one of the branches of the inferior epigastric, that you need to do that. That's something to take into consideration.
That's a great point. All right. Does anybody else have any questions?
Kartik, yes, Jeff, I have a quick question. So thank you so much for the presentation. Very helpful and eminently practical. One question that's a little different than what our standard practice has been in the lab is around using ultrasound for femoral access. And it's something that we are using increasingly frequently, but certainly haven't achieved its utilization in upwards of 100% like you have. My sense is that there's a learning curve about actually using it effectively. And I've been finding that I think we're, at least anecdotally, getting more high sticks associated with the use of the ultrasound because it's easy to identify the bifurcation, but it's a little harder to know where you are on the superior side. So can you talk about sort of your lab's experience in that journey to using ultrasound routinely?
I think you raised a very, very, very important point. Ultrasound is not benign. The other thing that happens beyond those that you identified very nicely is the use of micropuncture has led to, because the flow is not very robust, had led to some subintimal, wiring with the micropuncture wire, and then placing the sheet in a subintimal space, because you don't get a good flow from the micropuncture sheet, and you don't get a good flow from the micropuncture needle. So I think both of those are very important points. Number one, I would say is that just because you use ultrasound, doesn't mean that you shouldn't mark the groin with the Kelly clamp before doing the ultrasound. So we always do our technique is that we place the Kelly clamp and we fluoro, make sure that we are in the femoral head, because you're absolutely right. There is a learning curve. Even if you've done it for a long time, sometimes you get fooled and you end up going high stick. So that's one. So that gives us some guidance as to where we think it should be, the bifurcation, so we don't go too high. The second thing that we do is with the ultrasound is the staff is always there. So one of the things that I did when I came here is that a lot of times the fellows were getting access on their own and the staff was in the outside. I think that's a mistake in my opinion. And I think that the staff needs to be there, especially in the first few months of the year, so that, we know that how they train, because they haven't used ultrasound in this way. We don't do that in residency, that much. Now it's more common because of, triple lumens. And I think most ICUs now have ultrasound side right. But, when I was training, we didn't train in ultrasound. We did everything manually, by landmark. So I think the staff in there is another important one. The third thing is that if there is, when you're passing the micropuncture wire, if there is any resistance, you should look under the fluoroscopy. And the micropuncture wire can go to inferior epigastric. And exactly this is what happened to the case that I told you about, because they had used micropuncture or something they were doing. And so I think that if you have any resistance, you should be we should check on the fluoroscopy. And then the last thing we do, to be honest, is that before putting even the micropuncture sheet, we check on the fluoroscopy where our needle, the micropuncture needle is, and where the micropuncture wire is. So if we see that the micropuncture wire needle is very high, we may, after we put the micropuncture sheet, we may take a picture to see where we are. And if you see we are high stick, we pull everything, we hold pressure, we re-stick again. So there's 4 or 5 things that we do to ensure that we are in the right place. It's not just the ultrasound. I think, again, just to reemphasize, 1 is fluoroscopy with the Kelly clamp. 2, it's having the faculty by standby. 3, it's any resistance, check on the fluoroscopy to see where the micropuncture wire is. 4, if you don't even have resistance, once you feel like you have put the micropuncture, you are ready to take the needle out and put a micropuncture sheet, we check on the fluoroscopy, check the needle, see where it is relative to the femoral head, and then check the wire, make sure it's made it up the iliacs into the aorta. That way you are sure that, okay, I am up the aorta, I'm not in the inferior epigastric by chance or in one of the branches. And 2 is that you are not high or low. If we feel we are high or low, we then put a micropuncture sheet and we take a picture. If we are high, we take everything out and re-stick again. It's a pain, but I think you have to do it, especially if you're doing large bore procedures like TAVR or Impella, or you're going to do an intervention, you're doing the PCI. I think you have to do these steps.
And in terms of the ultrasound view, do you use the transverse view, or are you a proponent of the sagittal view? Because there's been a push of that recently.
Yeah, I
like the
like
artery in a sagittal view.
Yeah, I like the cross-sectional view, to be honest with you. I don't like the sagittal view because the patients have a big pannus. And maybe this is the way I have trained myself and I learned. And so I also use ultrasound to get access in other areas of the body, especially in the leg, because I do a lot of retrograde access like Carlos does and others in your group. And in that area, the sagittal view, helps us because we want to see the wire. Here, I feel like the artery goes deep, the external iliac artery. Our ultrasound machines are not the most robust machines. We have a side right, small little thing. Patients are obese. I can't rely on that. So instead of doing that, I use the fluoroscopy to make sure that I'm not too high and that my wire is in the right place. So it's a little bit more fluoro, but it's not that long, it's seconds, I think if you have a good machine and you can see the vessel well, and there's not a lot of pannus and you're comfortable with the sagittal view, I think it's nice to go back and forth. I don't think it hurts. But, I am currently, and the way I teach it to the fellows and our program, I think most of our operators use it in a cross-sectional view.
That's great.
But I think the sagittal would probably tell you if you were subintimal, if you had good imaging. That's the benefit maybe of the sagittal.
Anybody else have any questions?